everyone, and welcome to our EBAC accredited webinar from the ISCP's A to Z of CV Pharmacotherapy series. So today's program will focus on Edoxaban, engaging in individualization of DOACs. So today, my name is Claire, and I'm an ISCP governor for Singapore, and also a senior pharmacist at Tan Tock Seng Hospital in Singapore. At the same time, I have my co-moderator here, who is Dr. Ann Leung, who is a lecturer and Master of Clinical Pharmacy Coordinator at the University of Hong Kong. And it's with pleasure today, that we are also joined by a fantastic faculty. Okay, so just to introduce us once again, so my name is Claire, and moving on, we have Anne, who is a lecturer at the University of University of Hong Kong and at the Department of Pharmacology and Pharmacy. So she's currently the program coordinator of the Master of Clinical Pharmacy and Master of Advanced Pharmacy program, and she will be leading the case discussions today. Following, we will introduce our panelists today. Our speaker is Dr. Doreen Su-Yin Tan, who is an Associate Professor of Clinical and Pharmacy Practice at the University of Singapore. So Dr. Tan's research interests include person-centered models of care, value-driven outcomes, pharmacogenetics, cardiometabolic disease management, pharmacotherapy, and drug interactions.
Hello, everyone.
So moving on, I'll introduce today our panelists. So first up, we have Dr. Gheorghe-Andrei Dan. So Dr. Gheorghe-Andrei Dan is head of Internal Medicine University Clinic at the Colentina University Hospital, Bucharest, and head of the Cardiology Department and Diagnostic Cardiovascular Procedures and Arrhythmology Unit at the University Hospital of Colentina. Dr. George can say hi to our audience.
Hi. Hi, everyone. Hi.
Okay, and last but not least, we have our last panelist for today, who is Dr. Oskars Kalējs.
It's more or less correct,
so Dr. Oskars Kalējs is a professor at so he's a professor at the Latvian Center of Cardiology and chief of the arrhythmia service at Paul Strandin's University Hospital. So Dr. Kalējs is very active in the field of clinical electrophysiology and participates in all national and many international meetings in the field. Dr. Oskar, do you want to say hi to our audience?
Hi.
Okay, so today's broadcast is supported by the International Society of Cardiovascular Pharmacotherapy and brought to you by Redtive Cardiology. So this will be an interactive session, which will actually feature a 10-minute live session Q&A. So please feel free to submit your questions to the faculty via the question module at the webpage, and we'll endeavor to answer as many of them as possible towards the end of the broadcast. So to kick off the session, I'll hand over the time to Dr. Doreen Tan, who will be going to start her presentation on Edoxaban, engaging in individualization of DOACs. Dr. Doreen, please.
Hello, good evening. Thank you for having me. I was told to give a very cheery welcome to say, ta-da! Here I am. So thank you for joining us in the evening. And this evening, we're going to be talking a little bit more about Edoxaban, but I think it's quite important for us to also explore the overall overarching information about all the DOACs per se. So what will we cover for today? We will be thinking about the basics of the DOACs or NOACs, depending on where you're coming from, disposition of the DOACs, the dosing of DOACs in SPAF, which is stroke prevention in AF, and VTE, and 3 areas of key consideration for renal function, elderly underweight, as well as drug-drug interactions. For the purpose of the presentation today, because it's going to be a really short time, I'm going to be focusing on the role of Edoxaban or DOACs in AF rather than VTEs. So what are antithrombotics? As a very important topic that we have to cover as an introduction, a lot of people are quite mixed up about antithrombotics, anticoagulants, and antiplatelets. So antithrombotics comprise of both the antiplatelets and anticoagulants, right? And of course, the group of interest today is really the anticoagulants, and specifically the oral anticoagulants, which are best represented by the vitamin K antagonist or VKA warfarin, as well as the DOACs, dabigatran, rivaroxaban, apixaban, and of course the drug of interest today, which is Edoxaban. So let's go to a very important cascade where the coagulation is concerned. With every good pharmacotherapy lecture, we must start off with the mechanism of action. So essentially, all the sabans, the rivaroxaban, apixaban, edoxaban class of agents are actually inhibiting the conversion of factor 10 to 10A. And that's why you can find the alphabet XA in the names of these various DOACs with respect to their naming nomenclature. Dabigatran very much inhibits the conversion of factor 2 to factor 2A. And essentially, this whole class would be very different than the warfarin, which actually inhibits the production of clotting factors 2, 7, 9, and 10. So while this is quite indirect, the other agents, which are the newer agents, are actually more direct. And therefore, in various cases, they could be called non-vitamin K oral anticoagulants. They could be called direct-acting oral anticoagulants or target-specific oral anticoagulants, clearly because of the difference in the mechanism of action. So this is a very busy slide, and obviously I'm not going to be going through every single detail right here. This is what I expect the pharmacy students to be memorizing. But for the purpose of the discussion today, I want to highlight a couple of points. And the first one is about the half-life of the various DOACs that we are referring to. And as you can see across the DOACs, the half-lives of these DOACs are somewhat a little bit more than just half a day. And that's important because this is why we tell our patients to comply with the medications, because the moment they miss 1 to 2 doses, they could actually be getting almost nothing in their bodies. That's as opposed to warfarin's half-life, which is a lot longer. And therefore, the lack of compliance probably is not as important for warfarin, whereas it might be more important for the DOACs per se. The next thing that I wanted to highlight is really the protein binding. And the protein binding is very much involved with also how much the drugs are variously cleared by dialyzability. And also how much is renally being cleared is a combination of both protein binding as well as renal clearance. And if you look at the profiles over here, edoxaban is very highly cleared by dialysis as opposed to dabigatran, mainly because the renal clearance, as we'll talk about in the next slide, is a lot less than that for dabigatran. Whereas for the other sabans, they are very much very much dependent on liver and not so much of the kidneys, and therefore they're unlikely to be dialyzable. And the protein binding is quite important with respect to the considerations of dialyzability as well. Metabolism-wise, the two sabans that we're talking about, rivaroxaban and apixaban, are very much metabolized by the CYP enzymes like CYP3A, and for rivaroxaban, CYP2J2 and some others. Whereas for edoxaban and dabigatran, you don't see so much of the CYP enzymes, so they're not as dependent on the liver clearance, and therefore you don't expect as much drug-drug interactions with respect to CYP3A4. Lastly, the important aspect of P-glycoprotein transport is an important consideration for all the DOACs, not so much for warfarin. And this presents to us new opportunities to be watching for drug-drug interactions involved with the PGP in proteins as well. So what is the disposition of DOACs like? If you look at this particular schema over here and going from left to right is where urine and liver clearance is important, you would see the abbreviation DRAW, and that's by dabigatran, rivaroxaban, apixaban, and warfarin, right? So as you go from left to right, you are more and more dependent on the liver for clearance, whereas for dabigatran is very much cleared by the kidneys as an unchanged drug. For edoxaban, I had put it right in the middle, mainly because it's 50% cleared by the kidneys. And interestingly, it's not as cleared by the liver. However, a lot of it is being cleared in the bile and the feces. And therefore, the dependency on CYP is not as high as the rest of the anti-10A inhibitors. So the guidelines now recommend the use of DOACs over VKAs in SPAF. And it's small wonder why, right? Because across the board, we know that the randomized controlled trials have shown very much favorable effect with respect to safety compared to warfarin. And this is the same for European or American guidelines. So what do ACs really do for SPAF? Well, the VKAs firstly reduce the risk of stroke by 64%, a whopping 64%, and the risk of death from AF due to stroke by 26%. So anticoagulation as a standalone is pretty much a very impressive way of preventing death with AF patients. Now, introduce the DOACs, and the DOACs actually reduce the risk of ischemic stroke by an additional 19%, and yet half the risk of intracranial hemorrhage by 50% compared to warfarin. Now, is that impressive or what? So going over to just the dosing of OACs for stroke prevention or SPEF in atrial fibrillation, I just want to highlight a couple of things here. And my goal is not to make everyone memorize the dosing because a lot of them have got their idiosyncrasies as you look at them over here. So I just would like to highlight that apixaban and edoxaban are slightly different than the rest of the agents, mainly because they would ask you to adjust the dosage based on clinical risk factors. For example, for edoxaban, we look for any one of the risk factors like creatinine clearances of less than 50, body weight of less than 60, concomitant use of some of these drug interactions that we need you to adjust the dose from the usual 60 milligrams to 30 milligrams per day. The other thing that we want to watch out for is across the board, for anyone with crack clearances that's impaired, like crack clearance of less than 50, there's a need to think about dosage adjustments. For apixaban, because you use that on top of any one of the other two risk factors, for rivaroxaban and edoxaban, it is an automatic adjustment from the original dose or the regular dose in AF to a reduced dose in AF. Right at the bottom over here, I'd like to call your attention to the creatinine clearances that are less than 30. I'd just like to highlight that for all the clinical trials involving the DOACs, that the people with crack clearances of less than 30 mL per minute have been excluded. And for the apixaban, the people who have got crack clearances of less than 25 mL per minute have been excluded. So a lot of these recommendations are very much based on the pharmacokinetic studies, and essentially the labeling for apixaban for hemodialysis was very much based on PK studies as well. So the focus is on edoxaban today, and so I'd like to stress that based on the above recommendation, anyone with crack clearances of 15 to 30 mL per minute, you want to give 30 milligrams per day. The people with crack clearances of less than 15, edoxaban is not recommended at all. So here, someone asked me about this icon earlier, and these are like explosions. These are symbols for you to watch out for because they're additional considerations, especially when you're using drugs together, they're interacting with the various DOACs. So we'll talk about this drug-drug interaction aspect a while later. Right here is the dosing regime for the treatment and prevention of VTE. And if you look at the rivaroxaban and apixaban, you find that it's quite unique in its dosing in what we call, and so somewhat like an induction dose for rivaroxaban and apixaban when you first start them off in VTE treatment. On the other hand, for dabigatran and edoxaban, you need to start the therapy with parenteral agents in overlapping for about 5 days before you give the oral monotherapy of the two agents going forward. So for edoxaban, you might actually see some labeling that for people with supranormal or crack clearances more than 95 mL per minute, that edoxaban is not recommended. We will explore this a little bit later. So as mentioned, I will focus a little bit about the kidney function for a while. And going over to this very important slide, although it's very busy, just you have to trust me over here. What we're trying to say here is that the benefit of DOACs is preserved across deteriorating renal function. Okay. There's some key observations to pay attention to. Now, there's some controversy involving warfarin, and that's associated with the greater deterioration of renal function compared with the DOACs over time. And because of this particular relationship, it's believed that the VKAs are associated with nephropathy and vascular calcification, particularly in the TKD population. They are taking calcium as well as phosphate binders. And therefore, this could imply, and this again, I stress, is implying that the long-term outcomes could continue to improve beyond the 1-year studies that we've seen in randomized controlled trials, when you compare DOACs versus VKA per se. So again, this is a postulation, but the key thing is really that we need to pay attention to the fact that the benefit of DOACs is preserved across deteriorating renal function. So here's the schema from the JAC reference in 2019, and it talks pretty much about the renal function spectra for which we should be using or DOACs, basically in the AF population. And as I mentioned earlier, anyone with a crack clearance of less than 50, please think about adjusting dosage. Anyone with less than 30, actually, they were excluded from clinical trials, but a lot of the recommendations was based on PK studies. Anyone that's on dialysis, actually, a lot of the studies with apixaban was based on PK, and that's why the recommendation for the US guidelines was to use apixaban in hemodialysis patients. But that population is another kettle of fish altogether and out of the scope for today's discussion. So if you have difficulty trying to recall what we've just discussed over here, we have prepared a very nice pull-out or cheat sheet for you on the platform of the ISCP website. And here there's a pull-out sheet or cheat sheet, and you can use the QR code or the links in the slide over here. And this particular cheat sheet has got all these references on the dosage adjustments with respect to renal function. You can take a quick peek or picture of this particular slide here as you listen. So I'd like to go over to a very basic assumption, and this is something that a lot of people have forgotten to take care of. This particular schema was published recently in the JACC Asia in 2022. And what this particular schema is trying to tell you is that there's a difference when you try to use a different equation to calculate eGFR or kidney function. So the key slide, the key message over here is to tell you to always use the Crocroft-Gault equation to calculate renal function when you're trying to adjust doses for DOACs. When you try to use the other equations, for example, CKD-EPI and MDRD, we know that these are very much used for staging of kidney disease and not as good for dosing. And this particular study has actually proven to us that the DOAC dosing has to be dosed off Crocroft-Gault equations, or the creatinine clearance has done of that. If you look at the particular reference over here, again, another CLEP that's produced by ISCP, you can get a bit more of the information on renal function and drug dosing from this particular clip. So what about people with too good renal function? And as mentioned earlier, there's this controversy that we shouldn't be using Edoxaban in people with very high creatinine clearance or supranormal creatinine clearance, right? So essentially, this particular subgroup analysis is from the original ENGAGE study, which got Edoxaban labeled for AF, stroke prevention in AF. And you can see over here that there's a slight increase in the incidence of stroke for the high-dose Edoxaban group. And if you look at the schema at the bottom over there, you can see that the trough levels of Edoxaban tends to become lower and lower as the renal function increases, thereby causing this particular impression that supranormal renal function could be a caution. This particular chart on the right-hand side shows you similar things as the one in the table on the left-hand side. And because of the sensitivity involved with Crocroft-Gault equation and the assumptions as mentioned earlier, the Crocroft-Gault equation tends to overestimate creatinine clearance in this supranormal population. And therefore, this same group actually uses sensitivity analysis with CKD-EPI, which is a different equation to estimate renal function. And this relationship with the strokes and outcomes that's increased even with a higher dose of Edoxaban is also observed with respect to increase over warfarin with a very good renal function population. However, I'd like to caution that we may be over-interpreting this subgroup population because it's really very small in the subgroup analysis. Overall, I think that we may be overthinking it because as a systemic stroke outcome with respect to both groups, whether it's warfarin or the high-dose Edoxaban subgroups, and with this very high CHET score of 3.5, the expected rates of stroke would be actually over 5%. However, the strokes risk, if you see in both groups numerically, is less than 1.1%. And therefore, I would say that Edoxaban in the high dose dosing is still effective with respect to stroke prevention in AF. So again, this is another database study, and this is a Korean real-world study to show you that actually what we need to be paying attention to is this group again. And this is some signals here that seem to suggest that Edoxaban has a higher risk of stroke compared to warfarin in their database. However, when this group looked in a subgroup analysis, they realized that these people with a higher risk of stroke were really the people who were inappropriately dosed with too low Edoxaban dosage. And so this is a reminder to please prescribe the doses according to labeled dosing. If your patient does not have a reduced renal function, please do not reduce the dose of DOACs because you're fearing the risk of bleeding. Some considerations for the elderly, I think a lot of people are worried about falls in the elderly. So remember that even though in the ENGAGE as well as Aristotle studies, the number needed to treat for those compared to a risk of falling versus those not a risk of falling is still a very good number needed to treat. And therefore, we should not withhold anticoagulation from the elderly just because we think they're about to fall. The evidence in the elderly is very much preserved. And this is a network meta-analysis comparing all the DOACs. Please do not read between too much into the lines because there's never been head-on studies and this is a network meta-analysis. However, what I just wanted to point out that the benefit of the ICHs is still preserved for all DOACs over warfarin. DOACs are still better than warfarin with respect to major bleeding, particularly for low-dose Edoxaban and apixaban. And the stroke and systemic risk benefit is still going to be preserved across the board with some superiority suggested for dabigatran, higher dose, as well as apixaban. So what about the extremes of body weight? You can see that for Edoxaban per se, we don't have to worry too much about the cachectic population. And therefore, that leads to this particular recommendation that since the labeling for both apixaban and Edoxaban labels have got the body weight adjustments in their labels, you could actually use apixaban and Edoxaban for low body weight patients of less than 60 kilos. However, again, please be very careful about the estimation of renal function and be using the correct equation when you're trying to estimate renal function. For the higher body weight, there's limited data, but it seems like rivaroxaban and apixaban might be better. This last part is on the drug-drug interaction, and I think it's something that we have forgotten to think about. And this schema over here is to show you the different clearance mechanisms for the DOACs. And the DOACs, we have got extra considerations with respect to the protein transporters like PGP as well as OATP. The good news is, I think for Edoxaban, that there's not that much of a dependency on these proteins, and therefore we don't have to worry so much about the use of Edoxaban whenever you're worried about drug-drug interactions with respect to OATP or PGP enzymes. So in this particular schema, this is basically taken out of EHRA guidelines. And just to remind everyone that there's a guide at the bottom of the tables that you need to take care of, basically for the yellow shaded portions. If a person has got 2 or more yellow factors, then you need to think about dosage adjustments. If someone has got a red box over there, you need to be thinking about contraindication for that particular DOAC. And for the people with blue, it means that the DOAC co-administration is reduced in terms of its efficacy, and therefore you might need to think about modifying your choices. So this is an example of how the tables look like. And if you focus on the top over here, they talk about the PGP as well as 3A substrate mechanism. And as mentioned earlier, Edoxaban is not dependent on CYP3A4 for its metabolism. And therefore, with any drug interactions with respect to CYP3A4, Edoxaban is a drug that you can consider because you don't have to worry so much about the CYP enzyme interactions as well. So where the yellow and the red and the orange boxes are concerned, as mentioned earlier, there's a guide. And if you saw somebody with, say, verapamil and perhaps an older person or someone with poor renal function, that's when you need to think about adjusting the dose for Edoxaban. And this is how you use the table from the HRA guideline. So a little bit about the ISCP CLAP guide again, and this is again shared with you earlier. There's this little blip about 3A4 and PGP and what's the fuss all about. There are some drugs that are suggested over here. If you wish to have some sort of a reference, you can download the cheat sheet. And again, this is the QR code. On the front side, it talks about the appropriate renal function equation to be using and some suggestions of the dosing with respect to SPAF as well as VT treatment and risk reduction and VT prophylaxis, and a small blip about liver impairment and cirrhosis. So with that, I just like to conclude by saying that we are still a learning community because we're still learning more and more about the DOACs. And so I'll hand the time over to the panel for that case discussion. Thank you very much.
Thank you, Prof. Doreen, for the very insightful and excellent summary on DOACs. With the increasing use of DOACs, I'm sure we will find all these tables come in handy. So we'll have time for questions after this next discussion segment. So I'd like to remind you all to keep submitting your questions, and we'll cover as many of them as possible later in the broadcast. But firstly, we'll now move on to our case presentation as well as panel discussion that will be led by Dr. Ann Leung, including our various panelists which will chime in to provide their expert opinion on the subject. Dr. Leung, over to you.
Great. Thank you very much, Doreen. That was an excellent summary, and many of those concepts you brought up will be demonstrated through these cases. So today I have 2 cases. The first one is on atrial fibrillation. It's a case that we see kind of often in Hong Kong. So we have Miss XA, who is an 82-year-old lady. And she was actually admitted to the internal medicine ward from her follow-up at her renal clinic. And so as you can see that she has CKD, so she was at the renal clinic and she was describing these symptoms of dizziness, shortness of breath, and tarry stools for the last 2 days. So because of these symptoms, she was admitted for further investigation and management. She's hemodynamically stable and her oxygenation was fine. When you look at her past medical history, she has paroxysmal AFib. Her CHA2DS2-VASc score is quite high at 8. You can see because of her age, 82, as well as being female, having hypertension, a history of TIA in 2018, and also being diabetic and also having vascular disease she does have a significant stroke risk. Her last MI was in August of 2019, and she got one drug-eluting stent at that time. And following PCI, she completed 6 months of clopidogrel in combination with Edoxaban, and then from then on, the clopidogrel was stopped, and she has remained on Edoxaban since then. She has the TIA from 2018, diabetes, hypertension, gout, and also CKD due to diabetes. And in terms of imaging, her heart is structurally normal, normal LV cavity size, her ejection fraction is around 55%, and her valves are essentially normal. And very typical of our population here, her body weight is quite low at 40 kilos, and she has no known drug allergies. These are her home medications. She's on Edoxaban 30 milligrams PO daily, appropriately adjusted for her renal function, as you'll see in a little bit. On metoprolol 75 BID for rate control, ramipril 5 milligrams daily for vascular protection, amlodipine 7.5 daily for hypertension, atorvastatin 40 daily post-MI, linagliptin for diabetes, allopurinol for gout, and on pantoprazole 20 daily for just general gastroprotection. In terms of her management in hospital, her Edoxaban was held. In the next slide, I'll just show you very quickly the hemoglobin. She chronically sits at around the high 7s. On the day she went to the renal clinic, they did her labs, and her hemoglobin had taken a small decrease to 7.2. And along with the symptoms, that's why she was admitted to hospital. So along with holding the anticoagulant, she received 1 unit of packed red blood cells, started on IV pantoprazole, and quickly went on to do an OGD, but it was unremarkable. So her esophagus, stomach, and duodenum were all normal, and there was no source of upper GI bleed. She stayed a few days in hospital. Her hemoglobin stabilized at 8.2, and there was no more complaints of blood per rectum or melena. And the plan is to discharge her home with a plan for early colonoscopy. These are her labs. So her creatinine sits anywhere from in the high 90s to 100s normally. On admission, there was a little bit of an AKI, creatinine 120. And this next part really demonstrates what Doreen was talking about, that the eGFR and the creatinine clearance often varies quite a bit. So her eGFR is usually in the high 40s, and creatinine clearance sits around in the 20s. Her lights were normal, urea was high. Generally, when you look at her CBCs, you can see that her MCV is normocytic to slightly microcytic, and she definitely has a component of iron deficiency. Otherwise, not shown on the slide, folate, vitamin B12, all were normal. So then, given this case of Miss XA, who is going to go home waiting for a colonoscopy, some points of consideration is what we would do about the anticoagulation on discharge. For a patient like Miss XA with poor renal function, low body weight, and elderly in her 80s, which anticoagulant would we choose and why? And if we do continue with Edoxaban, what dose would we use? 15 milligrams or 30 milligrams daily? And as Doreen alluded to as well, as her CKD worsens over time as she ages, we also might have to think about adjusting our anticoagulation plan all the way into dialysis. Okay, so with that, I'd like to open the case up for the panel to comment. Perhaps we can start with Doreen. Oh, actually, George.
So first of all, I congratulate Doreen for the excellent presentation in the short time, encompassing nearly all what is important in the dosage and the interference between NOAC and practical cases, renal dysfunction, elderly patient. Second, thank you, Anne, for this interesting case. I would like at this moment only to point on 2 different things. First, what is certain is that this patient this nice lady, above 80 years, deserve anticoagulation. This is no discussion about this. Second, there are several things I want to be a little bit tinted to provoke Doreen. I do not agree completely with the paper of Cheng, who told us that is to avoid dabigatran or edoxaban in people with low body weight. But this is a challenge, because the main things we had when the NOAC were introduced in the practice was that there is no monitoring. This applies to, let's say, 75 or 80% of population, but not to all. So for me, this patient could receive any of the NOAC with a condition to have the possibility to have a correct dosage of the level, of the plasmatic level of the NOAC. This is one indication on the few indication when we need the dosage of the NOAC. Second, as very important pointed by Doreen and also by Ann, when we are counting the renal function, we should use the formula used in the studies, irrespective of the fact we consider this the most viable or not. Of course, like you all, I like very much the CKD-AP, but CKD-AP was not used in the studies with NOAC, so we need to use Cockcroft-Gault formula, even it is not the optimal for characterizing the renal function. And the last thing I would like to point to this patient, I'm a little bit disturbed about the anemia of this patient. If you have seen, this is a decrease in hemoglobin, but the mean corpuscular volume is borderline normal. So it is very low hemoglobin is not a contraindication for anticoagulation. This should be very clear for everybody. But in order to indicate an anticoagulant, we should be very careful, especially in elderly person, in characterizing the anemia. It is probably of anemia of chronic renal disease, but I'm not sure about this. So this patient should be looked for any possible loss of blood, because if there is active blood bleed, the anticoagulant has no place in this patient. And I think it's enough. I stop now.
Absolutely.
Thank
So,
you, George.
Go ahead.
Maybe we direct the first questions of the case to Prof. Doreen. So, I mean, in the case, in your practice, if you see anyone with coming for a GI bleed that is on Edoxaban, elderly, low body weight, amongst all the NOACs, like what would be some of your considerations and what would be some of your preference from someone with such a history?
I think this is a field that is quite poorly lacking in evidence at this time, and we have to be very careful about comparing the incidence of GI bleeds across all the randomized controlled trials, because there hasn't been head-on studies comparing all the DOACs. There were some suggestions early on that dabigatran could be associated with higher GI bleeding compared to the rest, and some of the meta-analysis seem to suggest that the safest DOAC appears to be apixaban. So I do think that the more important thing to do with someone with GI bleed is really to look at the cause of the GI bleed and try to establish what it is about, treat that particular cause, because no matter what you do, if the cause is still there, no matter which DOAC you use, it's still going to be a problem for your patients. So I think that first and foremost has to be something that we need to look at. It's a bit too premature to conclude that one DOAC is better than the other with respect to a recurrent GI bleed. I think the more important thing is waiting for a critical time period after whatever definitive has been done, whether it's going to be cauterization or it's going to be any other way of stopping that bleed, for at least a minimum of 7 to 14 days. And I think that's the recommendation across for restarting of any anticoagulation, warfarin included.
Would the panel have a preference for apixaban, which seems to be the least renally eliminated, for patients who have impaired renal function?
If you ask me, I have no preference for apixaban, especially in the elderly. I sincerely prefer Edoxaban because it is one of the few who was checked in the frail patients, especially with the risk of fall. And Doreen has very clear emphasized a very old paper. We need to have roughly 300 falls in order that the fall is a contraindication to anticoagulant. So I have no preference for apixaban in this case. On the contrary, I would like to give Edoxaban to this lady, but again, you should be very careful because the renal function is marginal and the renal function is dynamic. So we need to monitor this patient to see if she is not crossing the border of the contraindication.
And sure, thank you so much. It's an excellent comment. And thank you, Doreen, your perfect presentation. My short comment is the one. I agree with you, is a big challenge for doctors and for all, at the same time for patients. We know doctors, what is the first problem typically for doctors is a bleeding. For patients, typically problem is most problematic is stroke and systemic embolism. But there's a challenge is here is a borderline and potentially frail patients and elderly patients typically have a polypharmacy. And here is my opinion, okay, I prefer the same option, not a special preference to apixaban. Edoxaban is an excellent drug in this case. But the one, we must check the concentration of the anticoagulant, check concentration. And another one, maybe we can move some pharmacy from morning to evening and another. Maybe some potential drug and drug interaction. For example, atorvastatin. Potentially, maybe we can move the difference between taking of Edoxaban and atorvastatin. It's my idea. The potential drug and drug interaction is a typical problem for elderly patients.
Thank you, Prof. Oskars, for your comment. Yep. Dr. Ann?
Yeah, so I was also looking into the dosing information in LexiComp, and Edoxaban has been studied in Japanese, really elderly patients in their 80s in the Elder Care AFib trial, in which if you feel like the dose according to label is not appropriate in terms of bleeding risk, you may decide to use even lower at 15 milligrams daily. Has the panel had any experience with that lower dose of Edoxaban?
Not in Singapore. Edoxaban just applied. It just came into our formulary in Singapore. So I wonder whether Gheorghe or Oskars had some experience.
If I'm allowed, only a small comment on the challenge made by the fact that in the Edoxaban control trial, a signal toward the less efficacy of the drug in higher filtration glomerular rate. If you don't mind, I will consider this like much ado about nothing. Because if you are following the papers, and there's a special analysis after Doreen presented it in a very good quality, you can see two very important things. That in the high filtration glomerular rate, the incidence of stroke and bleeding was very low, so low that it is practically impossible to make statistical correct estimation of this signal. Of course, there are pharmacological mechanisms to explain rapid clearance of the drug, but putting, as Doreen already showed, putting in balanced stroke and hemorrhage, the result is the same. So this is interesting. It is unusual, and I have seen in a lot of industry-sponsored symposia discussing against Edoxaban this aspect. Believe me, it has no clinical relevance.
Thank you very much. That was very rich discussion over this atrial fibrillation case. Are we taking questions now or after the last case?
I think we can move on to the next case, then we'll round up with the last question and answer session.
Okay. So then our second case, we're switching gears a little bit to a young lady now, a 24-year-old woman who was admitted to the emergency room due to a left lower limb DVT. And the way she presented was she noticed left posterior calf and thigh pain and numbness for about a day. And then she started to get alarmed this morning when she started to notice that her left lower limb was looking a little bit purplish in color. And upon physical exam and imaging, they found that her left lower limb was mildly swollen and cyanotic. Calf, of course, was very tender. Bilateral femoral pulses were still strong and symmetrical. Bilateral temperature felt around the same, and she was hemodynamically stable. When they imaged her lower limbs, they found on the left side there was lower limb DVT, grossly distended left iliac, femoral, and popliteal vein. And they also found on CTPA acute pulmonary embolism involving bilateral lower lobar and segmental pulmonary arteries. And so with all this imaging, she's newly diagnosed also with something called May-Thurner syndrome, basically where her common iliac vein and external iliac vein on the left side is occluded due to an underlying compression. And we'll have a picture to depict that in the next slide. Importantly, she does not have any family history of related to DVTs or VT. And her only home medication is a new combined oral contraceptive, Yasmin, that she started a month ago. No known drug allergies, and she's about 48 kilos. So before we were talking about May-Thurner syndrome, basically it's where the right iliac artery, where it crosses over the left iliac vein, it places a bit of compression on the left iliac vein. And because the left iliac vein is a bit narrowed, it predisposes the patient to forming DVTs on the left side. And typically, this is usually found when patients are first diagnosed with a VTE and they get all this extensive imaging done. So she's a young lady, otherwise healthy, so her labs are what you would expect. Her creatinine's great. Her EGFR is greater than 90, and if you do use the Cockcroft Gold, then it's above 100. Otherwise, her platelets are borderline. It was normal and then borderline high on discharge, and really nothing remarkable on her blood. But she was admitted for about a week. She received unfractionated heparin first, was switched over to enoxaparin, and then in preparation for discharge after 5 days of parenteral anticoagulation, switched over to Edoxaban. And her discharge medications were Edoxaban 30 daily, which is appropriately dosed because of her weight, less than 60 kilos, and on famotidine for gastroprotection. In terms of workup, most of the additional blood work circled around autoimmune diseases, such as ANA, ANCA, and some blood work was found to be borderline positive, like the ANA titer of 80 and C3, C4, that was just a little bit high. But overall, there was no diagnosis of any autoimmune diseases. There was no thrombophilia workup at this time. We did see that there were orders for protein C as antithrombin and lupus anticoagulant, but perhaps we think they were canceled because the patient was already on heparin for anticoagulation at that time. It's not clear from the notes whether she was advised to stop her oral contraceptives, but for the purpose of this discussion, we'll assume that she has. So she was offered two two directions of care. Because of the May Thurners, one was to do vascular surgery, endovascular thrombectomy, and angioplasty, plus or minus stenting of the common iliac and external iliac vein, and if needed, plus or minus an IVC catheter, IVC filter to be inserted. And the pros of that would be faster resolution of symptoms, reduced risk of post-thrombotic syndrome, and her anticoagulation can then be limited to 6 to 12 months after stenting. However, as she's a young lady, there was discussion about potential effects on pregnancy in the future, and that a stent would be required to be inserted. So the other way is conservative management, where she continues on anticoagulation. However, she would then require lifelong anticoagulation to be reassessed. So because her symptoms were relatively mild, on discussion with her family, the patient did decide to go for conservative management and went home on Edoxaban. So then 3 months later, she comes back to the eMERGE and complains of about a week of bilateral calf pain. Her left lower limb turns purple after walking for a few minutes, but her right limb is fine. Hemodynamically stable, oxygenation is fine. No signs and symptoms of pulmonary embolism like chest pain or shortness of breath. And she claims that she's been very compliant to the Edoxaban. And upon examination this time on Doppler ultrasound, a non-occlusive thrombi was found in the dilated left common femoral vein. There was no thrombus in the left femoral vein and the popliteal vein, and the right side was completely clean. And CT thorax was done. Her pulmonary embolism from 2 months ago had completely resolved. So then these were her labs on the recurrent VTE. And so as you can see, it's pretty similar to last time, still great renal function. So some questions to consider are the contributing factors to recurrent VTE in this young lady, and whether additional investigations would be beneficial. How we can alter this lady's management to prevent recurrent VTEs, and then circling around the excessively good renal function, is Edoxaban the best choice for her? So with that, I'll open it up to the panel again.
Maybe we can get Prof. Oskars to share his thoughts about the case.
Okay, let's meet you. Sorry, Oskar, go on.
No, sorry.
Go on.
But if we have a relatively young lady and potentially relevant high risk of thromboembolism, maybe it's not so often disease, but I always remember Trousseau syndrome is a potentially elevated risk of thromboembolism from this migrants, thrombophlebitis migrants is potentially risk of oncological disease. It's a one-off idea. It's a potentially risk of oncology. It's a question why? Why we have so high risk for thromboembolism? Why we have this provocation of hypercoagulative status? It's the first my idea. It's a young lady.
Thank you, Prof. Oskars. Maybe I'll highlight some things from the case that we can discuss. I think one thing that I saw was that she was on Edoxaban 30 mg daily, but actually she has like a really good crack clearance, which by the dosing schedule we would have dosed her at 60 mg daily. So I think apixaban falls into this category where if you fulfill 2 out of the 3 criteria, you will start to dose adjust. Same thing for Edoxaban, it's either a crack clearance or weight issue. Maybe I'll pass this question to Prof. George. In your setting, if you encounter someone like Miss Edie, where her weight is less than 60 kg, but her crack clearance actually is supernormal, even though I think you did mention just now that the supernormal clearance of more than 90 doesn't really affect the stroke or the stroke risk that much, would you still choose to dose the patient at 60 mg, or you will go ahead to do the less than 60 kg at 30 mg daily?
First of all, I would like to congratulate for finding such a rare and interesting case. I should confess I'm ashamed about this. In 50 years of experience, I have seen 3 cases. That's all. My experience with May-Turner cases, not so frequent, or maybe we overlook the cases because we are looking to other things. The only comment I would like to make to this case, not because it's so young, she was also on contraceptives, but I remember the quote, if you hear the hoofbeats, sings to horses and not to zebras. But in this case, I am not sure about this. I am not sure that the May-Turner syndrome of this young lady is not masquerading for something else. And let me to put a question to you. Which was your explanation for the calf pain the patient has even 3 months after the correct therapy with anticoagulants? In the description, you have said that the peripheral pulse is normal, but it is not enough. Have you any proof of the arterial competence beginning with a simple ankle brachial index or something in this patient? Because what I'm thinking about, besides the May-Turner syndrome, if this woman is not a candidate for thrombophilia, I have seen that you have looked for something, probably for the antiphospholipid syndrome, but incomplete. But there are other forms, like, for example, the 5-factor Leiden, which is especially augmented by the contraceptive drugs, or thrombin 200, 210. So what's the explanation for the symptoms of this lady after the correct treatment, and what to do next in order to be sure that the thrombophilia is not present in this woman?
Yeah, I was looking retrospectively at the charts, and it looks like these were all of the investigations that were done at that point. But absolutely, I think making sure that all the other possible underlying causes of thromboembolism is very important to uncover. And you're absolutely right. I had to reach out to all my clusters connections in order to find this one case.
So maybe I can jump in at this time. I think the more important thing to examine right now is the diagnosis behind why she had that DVT or the PE in the first place. And I think the discussions from Professor George and Oskars were both very important considerations. I think the key thing behind excluding all these other underlying issues is to see whether there are other things that we need to pay attention to. In the case of Professor Oskars, I think he's concerned about whether there could be some oncological or cancers that we might be missing, and that is a very legitimate consideration to think about. On the case of Professor George, I think he's concerned about whether there's thrombocylia, and I think that for that particular consideration, that would influence our decision for the duration of anticoagulation going forward, whether it's going to be indefinite, lifelong, or it's going to be a short course. So all this workup is critically important, and we have to remember that the use of OACs in any form, whether it's IV or it's an oral form, it would get in the way of a proper diagnosis of some of these clotting factors if we were to work up for thrombocylia. And so it's critical that we do them all properly right at the start, rather than having to think about when to disrupt the oral anticoagulation in order to work up the patient up again. So I think the considerations on both parts was important. I think the two of you wanted us to talk about whether the renal function and then the low body weight, because in opposite directions, right? Whether it's really that appropriate to be using Edoxaban for this particular lady. I have to say that there isn't much information about the use of Edoxaban with respect to very good renal function in the population of the VTE population. But that information that we had about the supranormal renal function applies to the people with SPEF, and that was a specific AF population. So to be honest, we don't really know about what the impact is going to be with a very good renal function with respect to VTEs and PEs. I would say that instead of picking on which OAC we should be using, we should be really, really grateful that we have so many different DOACs to choose from today. And I think critically, because there's so many things to consider, it's not just about the body weight or the renal function. There's also drug interactions that we need to be concerned about. Those are things that we might want to think about whenever the approach of DOACs should be taken. And I think in different countries, the funding mechanisms are different. In Singapore, for example, DOACs like rivaroxaban and apixaban are a bit more affordable. And recently, apixaban has entered the standard drug list. And so that becomes the most affordable DOAC for us. And therefore, we see a lot of prescribing towards the direction of using apixaban rather than the other DOACs. And because Edoxaban entered the picture rather late, it's still not subsidized. And so therefore you don't see that much of prescribing with Edoxaban. At the conclusion of my segment, I did say that we're a learning community. And I think that it's critically important for us to look into how DOACs are being used in our real world populations. Because I think you mentioned earlier about the elder care AF study, and that was the 15 milligrams of Edoxaban that was used, right? That particular population was particularly in octogenarians in Japanese. Whether that same benefit is going to be extrapolated to Caucasians or to Southeast Asians like us, we don't know. So I'll be very careful to try and extrapolate that small group population to all other populations all over the world. And so I think it's important for us to be grounded with the facts. So coming back to this lady with the VTE, I probably, in the light of Singapore's practice, would have used apixaban simply because it's funded. But it's also difficult to answer the question whether Edoxaban could have been useful for her. Perhaps when she came back with the recurrent DVT, we could have tried another agent, or we could first exclude whether she was compliant with her DOAC, or whether she was actually even taking her OCs unbeknownst to us. So there are many other things that we should be thinking about first before maybe trying to decide on which DOAC to be choosing right up front. So I guess the moral of the story I'm trying to make is really important to look at our patients holistically, consider all risk factors involved. Same thing for the risk of GI bleeding. I think it's fairly important to look at whatever we can minimize with respect to use of high-risk drugs. For example, if someone is on antiplatelet as well, then we could stop that earlier. Or if someone was using NSAIDs without our knowledge, stuff like that can be addressed upfront before the first bleed occurs. So I think by and large, it's fairly difficult to say that it's evidence-based for us to choose one DOAC over the other. It's probably more a bit of experience, a little bit about patient risk factors, the clinical risk factors, renal function, body weight, blah, blah, blah. There's so much to be thinking about. And therefore, it's important for us to be really grounded when we try to choose the DOAC and then dose the DOAC correctly. Let's not dose them wrongly. I think that is the summary I would make for today.
Absolutely. I think through these two cases, what really has come out is looking at underlying causes as well, rather than being very focused in exactly which DOAC, what dose, and so on. And absolutely, in our practice, we will refer back to the claps that Doreen has showcased, because it looks like a wealth of really great information. Thank you very much, panels.
Yeah. Thank you, Dr. Leung, for sharing these interesting cases. Prof. George, you have something to add?
I would come back a little bit to the case with the young lady. And if you have contacts with this patient, I would continue investigation for the thrombophilia for many reasons. One, already emphasized by Doreen, the duration of anticoagulation. But one is even more important. What anticoagulant? Because it is thrombophilia. We have no enough proof for NOAC, and maybe this lady should be put back to warfarin.
That's a really important point.
Thank you, Prof. George. Yeah.
Okay. All right. So thank you very much for an excellent session today. Today's proceedings will be available on demand at radcliffecardiology.com in a little bit. So please go there again if you would like to revisit the session or forward to your colleagues. And so before we go, we'll like to thank our faculty today for their fantastic contribution. Doreen, really excellent presentation. Thank you so much. George, thank you for being with us. And as nice to meet you as well, Oskars, and my co-moderator, Claire.
Thank you.
All right, so today we've talked a lot about CLAPS and all the other resources available through ISCP. We would like to take this opportunity to invite you to become a member, as there are many benefits, including access to journals and newsletters and a lot of discounts, etc. on Congress. So if you would like to sign up, please scan this QR code. And then I would like to also let you know the date for the next session in our A to C series is going to be on Entresto, valsartan, sacubitril. Should we HEF or MPEF and blow it off? So it's on Wednesday, October the 5th at the same time. For those of you in Hong Kong and Singapore, it's 7:30 to 8:30 or 1:30 to 2:30 CET. With that, finally, our thanks to you, our audience, for joining us. We hope that you have found the session insightful. And remember, this event is CME accredited, so please don't forget to submit your details to claim your certificates. Thanks a lot, and have a good evening or a good afternoon wherever you are.
Thank you.
Thank you.
Thank you. Bye.